Hello everyone, my name is Vishant, my friend again. Okay, so today we're gonna do the lungs, lungs physical exam. When my patient comes, I want to make sure that my patient is not in any kind of distress. He's not leaning forward to take a breath. My patient breathing rate is around like 14 to 16, so the normal is 12 to 20, and he's breathing at a very regular rhythm. You want to make sure that he doesn't have like a very high inspiration and exhalation that you see in the respiratory acidosis, metabolic acidosis. So he's doing good. So I expect that, and I'm also gonna inspect for just his chest. I'll make sure his chest is not too big. We want to measure his anterior posterior to lateral ratio and make sure that it is 0.75 to like 0.70. You don't want it to be more than 1 because that could indicate a barrel chest, which most of the people who have emphysema will have those barrel chests. One thing to note is I also want to inspect the back of my patient to make sure that he doesn't have any deformities in the spine area for like scoliosis and kyphosis. Okay, so once I'm done with my inspection, now I'm going to go with the palpation. So just want to measure, want to palpate his trachea to like make sure that it's not deviated anywhere. Any deviation could indicate that there's something wrong with the thyroid, there's a thyroid tumor or a cyst, or if the trachea is deviated to the right side, then maybe a sign of a right side pneumothorax. So those are the things you want to do. I also want to palpate his chest area for any masses, tenderness, anything on the back, basically to check for any pain. Now, okay, can you stand up?
Yep.
Now I'm gonna do the tactile parameters. So say like 99.
99, 99, 99, 99,
On the back.
99, 99, 99, 99.
Okay, have a seat. The reason I'm trying, the reason I'm doing this is to check for the resonance. So when he says 99, I'm supposed to be feeling the vibration. If I don't feel any vibration, then there's something going on with his lungs, like pneumonia or like consolidation of the lungs. I'm also gonna do the thoracic expansion. So have a patient stand up. Take a deep breath in and out. In and out, one again. Perfect. On the back. In and out. Out. There you go. Have a seat. The reason I'm doing this is to check for the thoracic expansion. When he takes in and out, you are supposed to make sure that both the side of the lungs are equal, expanding, and then goes down, up and down. So which he's in. So once I'm done with that palpation, now I'm going to do the percussion. Basically, in percussion, I'm checking to make sure that I hear a resonant sound. I don't, it's not dull. Okay, so let's lift up your shirt. Good sound. Okay, I'm gonna hear on the right side. Okay, don't forget the right side because the right side there's a three lobes. Okay, and I'm gonna do the same thing on his back. Sorry. Lift up your shirt. Okay. Yeah, there you go. Good resonant sound. I like it. forget the right side. Okay, perfect. I auscultated so okay, then while he's standing, well, I'm just gonna percuss your, I can also do the diaphragmatic excursion. So take a deep breath in and hold. Okay, go it out, let it out. Take a breather in, out, and hold. There you go. So, and I'll do the same thing on the on the right again. So take a deep breath in and hold. Okay, blow it out. Take a deep breath in, out, and hold. Okay, there you go, right over here. So what I was doing is, I told my patient to take a deep, here you can have a seat. I told my patient to take a deep breath in and hold, and I was percussing. So I'm supposed to percuss, and you're supposed to hear the resonance, and then you're supposed to hear the dull sound. So that I'll mark with a pen or like a Sharpie on the back, and then I'll tell my patient to breathe in again, out, in, out, and then hold, and then I'll percuss again from my last mark all the way to the up to see from where I hear the resonance again, and that should be between 3 to 5 centimeter, which in his case it was. So now once I'm done with my percussion, now I'm gonna auscultate the lung sounds. Okay, lift up here. Take a deep breath in and out and through your mouth, okay? In and out. On the back, in and out. Oh no, what happened? In and out. On the right side, on the right middle lobe, in and out. Okay. And once I'm done with my auscultation, now I'm gonna check for the vocal sounds. There are three vocal sounds. One is called bronchospony. Sorry, it's hard time. Hard for me to say that. So what I'm gonna do is have the patient sit up, or sorry, stand up. Say, yeah. I say Mickey Mouse.
Mickey Mouse, Mickey Mouse, Mickey Mouse, Mickey Mouse.
Okay. Say ah. Okay. Okay. Can you whisper? Okay. So I did that, bronchospony to check for, so when he said like Mickey Mouse, I'm supposed to hear like a indistinct and a muffled voice. If I hear a clear and a distinct voice, then there's something wrong with the consolidation of the lungs, pleural effusion, or pneumonia. If I, when I told my patient to say A or ah, then sorry, when I told my patient to say E, and if I hear ah, that means there's something wrong. And the whispered is like when he whispers, I'm not supposed to be hearing clear, distinct sound. And that is it for us. Thank you.